I think without uh, any further, we will get started here. So today we'll be discussing low gradient aortic stenosis. As Cheryl said, I'm one of the echocardiographers and valve specialists here at the University of Michigan. I have no relevant disclosures. And one question I have, can you see my mouse?
Yes. Yes.
Yes. Okay. Okay. So as all of you probably know, echo plays a critical role in both the diagnosis of aortic stenosis as well as the grading of aortic stenosis severity. So shown here is a zoomed in view of an aortic valve on the left here. This is from one of my patients where you see that he had a significantly thickened aortic valve and heavily calcified. You see that there's significant restriction of the motion of the two cusps that are visualized here. And so that we suspect, from the start that this patient is going to have significant aortic stenosis based on this view. But we can also use this view to make sure that there's no left ventricular outflow tract obstruction, which, there doesn't seem to be any evidence of that from the visual assessment. And then we move on to the Doppler evaluation. So having made our visual assessment, we know that any gradients that we're going to be measuring across the aortic valve are going to be due to valvular stenosis itself, as opposed to other reasons for elevated gradients to be there. And shown here in the middle is a continuous wave Doppler profile, which is showing the speed of blood as it's going through the aortic valve. And so the sonographers are trying to line up the Doppler with the aortic stenosis jet as much as possible to really try to show the maximal speed of blood flow as it accelerates through the stenotic aortic valve. And as you can see for this patient, he had a peak velocity of about 4.5 meters per second on this aortic stenosis jet. And we can also, but on echo, convert any measured velocity into gradients using this simplified Bernoulli equation down here, which shows that gradients between the left ventricle and aorta are equal to 4 times the velocity squared. So if we want to calculate a gradient, we can use this simplified formula to be able to take our velocity that we measure and convert that to a gradient. We oftentimes deal with mean gradient across the aortic valve, and so we're just looking at the gradient, under this line that I've traced here. So the area under the curve can give us the mean gradient. So ultimately, when we're trying to make the diagnosis of severe aortic stenosis, we use these measures to be able to confirm the presence of severe AS. So peak velocity of 4 meters per second or above, mean gradient of 40 millimeters of mercury or above, aortic valve area of 1.0 centimeters squared or less. We can also index the aortic valve area to body size by dividing by body surface area, or BSA. And we use these thresholds down below, where if a patient has a BMI of less than 30, we would use an indexed aortic valve area of less than 0.6 centimeters squared per meter squared. And for patients with a BMI above 30, we would use a stricter threshold of 0.5 centimeters squared per meter squared. And so for our bread and butter diagnosis, the more kind of straightforward diagnosis of severe aortic stenosis, which would be high gradient aortic stenosis, that's going to be a patient that has either a peak velocity of 4.0 meters per second or above, or a mean gradient of greater than or equal to 40 millimeters of mercury, and the presence of an aortic valve area of less than or equal to 1.0 centimeters squared. But the question becomes, what if there's not agreement between the measured gradients and the measured aortic valve area? So that would be called discordant aortic stenosis. And so you can really come up with kind of a 2 by 2 matrix of possibilities here based on the measured gradients as we see above, and the size of the aortic valve area being large in the top row here, or a small aortic valve area of less than 1 centimeter squared on the bottom row here. So starting with the top left, if somebody has low gradients and a large aortic valve area, well, that's, somebody that does not have severe aortic stenosis, perhaps moderate or maybe even less aortic stenosis. Going to the right here, if somebody has severely elevated gradients across their aortic valve, but have an aortic valve area of greater than 1 centimeter squared, this would be considered discordant high gradient aortic stenosis. And this can be due to a variety of causes. Sometimes it's due to concomitant aortic regurgitation. Sometimes it's due to a high flow state. The guidelines would typically say that if there's not a reversible cause for those high gradients that can be found and treated, then these patients should really be treated as if they had severe aortic stenosis. Going to the bottom right here, so these are patients that have a small valve area and severely elevated gradients. This is a pretty straightforward diagnosis that we make in the echo lab, which is severe high gradient aortic stenosis. But that leaves this final one here, which will be the topic of our presentation today, which would be what if patients have a low gradient, but they also have a small valve area of less than 1 centimeter squared? These would be patients that have severe or potentially severe low gradient aortic stenosis. And this comes in a few different flavors. So this can be low flow, low gradient aortic stenosis, or patients with normal flow, low gradient aortic stenosis. The low flow condition can be further broken down into patients that have a reduced LV ejection fraction or a preserved LV ejection fraction. So there's really these three different types or phenotypes of low gradient aortic stenosis that we'll discuss today. Just to give you a sense of the prevalence of these different hemodynamic profiles. So this was a study that we did here at the University of Michigan a couple of years ago that looked at patients that underwent TAVR over an 8-year period of time here at the University of Michigan. And we characterized their hemodynamic profiles according to the classification that I just shared with you. So these patients here in red, which are the largest segment of the pie, are those patients that had high gradient aortic stenosis. And although it's the largest group, you'll see that it actually is less than 50% of this entire population of patients treated with TAVR. And so that leaves more than 50% of the population that had low gradient aortic stenosis. And you see that this is broken down further into these patients in the yellowish brown here. 20% had low flow, low gradient AS with a preserved EF. These patients in the green here had low flow, low gradient AS with a reduced EF and accounted for 9%. And that leaves about a quarter of patients that have this so-called normal flow, low gradient aortic stenosis. So this is a fairly prevalent condition, and we really have to understand more about appropriately identifying these patients and treating them. So when I was initially learning about low flow, low gradient aortic stenosis, I found it to be a bit mysterious. And I think it is actually much more simple, understanding this over time, you realize that it's actually a fairly simple concept that I think all of us are already familiar with. I like to use the garden hose analogy here. And I think I may have shared this with some of you previously, but so here just to orient you to this picture here. So we have our spigot, which is controlling the flow of water going through the garden hose. Here's our nice green garden hose here with the flow of water going through here. And then this is showing just the opening at the end of the hose here. So when in this first scenario, we have the water flow rate turned all the way up, and we have the opening of our hose fully open. And let's say for the sake of argument, the water is coming out at a speed of 1 meter per second as it leaves the end of the hose. So what if you put your thumb over the end of the hose, as I'm sure many of us have done in our lives, and you've covered up now 3/4 of the end of the hose, leaving just a quarter of that residual end of the hose for water to flow through there. So what's going to happen to the water? if there
It
are
like
any.
flows a lot harder, farther.
Yeah, it's gonna shoot out faster, right? We've all experienced this. You're trying to hit those flowers that are a little bit out of reach, so you put your thumb over the end of the hose and the water shoots out a lot further. And so, in this case, because we know exactly how much we've closed off the hole, I can tell you that actually we can know how fast it's going to be coming out of the end. So if we have a quarter of the initial area, the speed of the water as it exits the hose is going to have to be 4 times as much. And the reason for that is we haven't actually changed the flow of water, going through the hose here. Okay, so we have this really narrowed opening at the end of the hose. So this would be kind of the equivalent of high gradient severe aortic stenosis, where you have normal flow going through the valve, you've closed off at least a quarter of the valve, and you have blood that has to rush through at a really high speed, generating high gradients across the aortic valve. Okay, what if we keep our thumb over the end of the hose so that it's the same, still covering up 3/4 of the end of the hose. But in this situation, now we're turning the spigot down and the flow of water has been cut in half. So now what are we expecting to happen to the water as it's shooting out of the hose as compared to that high speed of 4 meters per second?
They slow down.
Yeah, it's going to slow down, but we haven't changed the opening at the end of the hose. And if we truly cut the flow rate in half through the hose, it's going to be cut in half from that initial 4 meters per second to 2 meters per second. And so this is the kind of physiologic underpinning of low flow, low gradient, severe aortic stenosis. We still have a severely narrowed hose, and in the case of our patients, a severely narrowed aortic valve. But because the flow rate has been decreased, the the speed of flow going through the aortic valve is going to be decreased, and the measured gradients are also going to be decreased. So you still have that same narrowing. It's still severely narrowed, but we're going to be measuring lower gradients and lower velocities. Does that make sense? Any questions about that?
Physiologically, what makes the flow lower?
Yeah, that's a great question. I planted you in the audience here. I'll get to that in a couple slides. Very good question. Um, so so low gradient AS, as I just mentioned, being aware of the flow state is important because that might be the sole explanation for why the gradients are being measured low. So we can divide people into having low flow, which would be identified on echo using a stroke volume index of less than 35 mils per meter squared. So that's indexing the stroke volume to body surface area. So this is a pretty easy calculation that we can make by echo. Or we can identify patients that have a normal flow state. The low flow state can be further divided based on the ejection fraction. So patients that have an EF of less than 50% have low flow, low gradient AS with a reduced EF. Those that have an ejection fraction of 50% or more have low flow, low gradient AS with a preserved ejection fraction, which is sometimes called paradoxical low flow, low gradient AS. And then finally, patients that have this normal flow state can be considered to have normal flow, low gradient AS. And so getting to the question of, well, what causes this low flow to even occur in the first place? And remember, the aortic valve doesn't know what's causing this low flow. So, what matters from a gradient perspective is the flow rate. But then clinically, it's important for us to consider what are the causes of this low flow. And that's where it gets broken down into these two larger groups here. So there's the low flow, low gradient AS with reduced ejection fraction. And this is really where it's the weak heart muscle and the lack of the heart muscle being able to provide that oomph to generate that flow. And so the low flow is due to the underlying LV dysfunction. This is usually due to primary cardiomyopathy. So ischemic cardiomyopathy is kind of the most common scenario that you might see here. But rarely it may also be due to the progressive effects that aortic stenosis have on the left ventricle. So this concept of afterload mismatch ultimately leading to LV dysfunction from the AS itself. And that's in distinction to these patients that have low flow, low gradient AS with a preserved ejection fraction. So these patients have low flow despite having a normal systolic function. And there can be a variety of causes of this. The classic cause of this, though, is that some patients, while the AS progresses, instead of having LV dysfunction, actually have remodeling of the heart where they get increased thickness of the walls of the heart, and the LV chamber size can actually decrease. So even though they might still be ejecting 60% of the blood out of their LV chamber with a normal ejection fraction, if you're starting with a smaller chamber size, there's going to be less flow that's going through the aortic valve. So that's kind of the classic situation that we see, especially in elderly women. That tends to be, the form of remodeling that we see with aortic stenosis. But there can be a number of other reasons that people can have low flow, including mitral regurgitation, where the flow is going backwards instead of through the aortic valve. AFib, especially with faster heart rates, can decrease the flow per beat. Severe TR can decrease the forward flow. And for all of these low gradient AS cases, we always have to consider measurement error as causing a falsely low aortic valve area. And we'll, discuss that in a little bit more detail. So to be able to understand these patients with low gradient aortic stenosis, I think it is important for us to have an understanding of how do we even calculate aortic valve area. And so this is something that is done in echo using what's called the continuity equation. And it really requires three measurements for us to make by echo to calculate an aortic valve area, which are listed here. And here's kind of the illustration that will demonstrate this. So here is blood flow going through the left ventricular outflow tract, or LVOT, and it's approaching this aortic valve, which is narrowed and has a small opening to the valve. So the continuity equation just says that flow within the left ventricular outflow tract has to be the same as flow going through the aortic valve because there's no flow that's being diverted elsewhere. And so if that's the case, then we can break down this equation a little bit further, where we can actually calculate the flow within the left ventricular outflow tract, and we can calculate the velocity of, or measure the velocity of blood flow going through the aortic valve. And so this continuity equation breaks down into this, which is we can measure the area of the left ventricular outflow tract, this green circle here. We can measure the velocity at that point. And then we can also measure the velocity of blood as it accelerates and goes through the narrowest portion of the aortic valve where the velocity is going to be highest. Then we can, change around the equation with algebra. And ultimately, this is how we calculate the aortic valve area. So although we usually measure the diameter of the left ventricular outflow tract, we can change that to a radius, square that, multiply it by pi. That gives you your area of your LVOT. We can directly measure the velocity within the LVOT, and then we can also measure the velocity going across the aortic valve. So let's talk about a case and kind of put some of this into practice here. So this is one of my patients. He's in his 80s. He has known coronary disease, ischemic cardiomyopathy, and aortic stenosis, and he's been having worsening fatigue. So we repeated an echo, and it showed that his EF was stable, but he does have a significant cardiomyopathy with an EF of 30%, as shown here. And then you also see that he has a significantly thickened and calcified aortic valve. It's very restricted as well. And here are some of the values that we got here. So To calculate the aortic valve area, we measured the left ventricular outflow tract diameter as shown here. We really want to make sure that we are fully opening up that area because it's easy to underestimate this. But with this diameter, we can get an area of about 4.2 centimeters squared. We can use pulse wave Doppler, um, which is measuring the velocity of blood flow at the specific point below the aortic valve here. So it's a little bit hard to see, but you see these two little hash marks here. That's where we're setting. I want to know what is the speed of blood flow at this specific point. And from that, we can get this velocity profile during systole. We can measure the peak velocity. We can also measure something called the VTI, which stands for velocity time integral. All that is the area under this curve, and this comes out to units of centimeters. So the VTI in this case was 11.4. And between these two calculations themselves, we can calculate the stroke volume. So calculating the stroke volume and then dividing by the patient's BSA gives us a stroke volume index of 25 mils per meter squared, so it was low for this patient. Then going to our continuous wave Doppler, where we're trying to find the highest velocity of blood flow going across that aortic valve. We see here a peak velocity of 2.4, mean gradient of 15, and ultimately we were able to calculate an aortic valve area of 0.9 centimeters squared. So based on this information, what would be the diagnosis that you would give this patient? All right, so we have our low valve area, right? We also have a low stroke volume index and a reduced EF. So this is going to be a patient that has low flow, low gradient AS with a reduced ejection fraction. And then the question becomes, well, what is the severity of the aortic stenosis? And to answer that, I actually have to introduce one more concept to you, which is the concept of pseudo-severe aortic stenosis. So some patients, when you increase the flow across the aortic valve, the valve actually opens up better. And the reason why on a resting echo, we might be measuring a low aortic valve area is because the valve is not seeing enough flow to fully push open the valve. And so we can actually test for this in both the echo lab and the cath lab. And in this situation, similar to the patient that we have here, we see a mean gradient of less than 40 and an aortic valve area of less than 1. But then we give dobutamine in the hopes that we can augment flow going across the aortic valve. For patients that have truly severe aortic stenosis, when you see that increased flow going across that aortic valve, that's going to result in a high gradient, so a gradient that goes above 40, and the valve area is going to remain less than 1 centimeter squared because the valve area is relatively fixed and it's truly severe stenosis. As compared to a patient with pseudo-severe stenosis, where as you increase the flow, the valve is actually going to open better and the mean gradient will remain below 40 and the valve area will increase above 1 centimeter squared. So that's exactly what we did for this patient. So we did a dobutamine stress echo. We usually use increments of 5 mics per kg per minute. He got up to a peak dose of 15. And with this, we saw that his stroke volume index increased from 25 to 32 mils per meter squared. The mean gradient actually didn't really change much. It stayed at 15. But we did see that the valve area increased from 0.9 centimeters squared up to 1.4 centimeters squared. And so what would be the diagnosis based on this?
That your pseudo severe?
Yes, excellent. So this would be consistent with pseudo-severe. So we see that the valve area is increasing above that threshold of 1, and our mean gradient is remaining low. So this is a patient that actually had moderate aortic stenosis instead of severe. And so we're continuing to follow him clinically. So here's another situation. So this is another one of my patients. He's an 82-year-old patient with coronary disease, known AS, who is referred because of worsening shortness of breath. We get a baseline echo. His EF was 42%, peak velocity 3.7 meters per second, mean gradient 26. He had a low stroke volume index of 30 mils per meter squared and an aortic valve area of 0.7 centimeters squared. So again, we do a dobutamine echo for this patient, and he did have significant augmentation in systolic function. In fact, it normalized with dobutamine. His peak velocity increased up to 4.0 meters per second with a mean gradient up to 36. His stroke volume index also increased up to 33, but the aortic valve area remained low at 0.7 centimeters squared. So what would be the severity that we would apply for this patient?
That'd be truly severe.
Yeah, exactly. So this is true severe aortic stenosis. Good. So this patient was treated with a TAVR and is feeling a lot better. His LV function has improved and he's able to return back to his previous activities. So another way that we can look at the flow state, I know I've been mostly talking about the stroke volume index, which is how much blood is moving across the aortic valve per heartbeat. But another way that we can look at this is looking at the aortic valve flow rate. And a normal flow rate is 250 mils per second. This can be fairly easily calculated. We don't always do this on echo, but can be easily calculated where if we know our stroke volume, which was 64 for this patient, if I measure the systolic ejection time, which is just shown in this yellow line here, which was 0.32 seconds, that would give us an aortic valve flow rate of 147 mils per second. So he had a low flow rate. And we can actually use this to kind of track how the valve is performing under these dobutamine conditions. So let me just briefly orient you to this figure. So this on the vertical axis is the aortic valve area here with our threshold of 1 above this is highlighted in blue. And then on the horizontal axis is the flow rate. And once you get to a normal flow rate, you'd be in this green side over here. So for the first patient I showed you, he started with a flow rate just under 150 mils per second. And even though he didn't normalize his flow rate up to 250, we see that there was a significant increase in his valve area out of the severe range. So this is a patient that had pseudo-severe AS. The second patient, his flow rate did increase, but again, didn't quite normalize. But we still have established the trend here. And if we projected out to a normal flow rate of 250, he still would have remained below this aortic valve area. So this patient didn't have any change in his aortic valve area. Some patients might have a slight increase, but you could see that the trend would still be likely that they would stay below 1 centimeter squared. And so we can use that projected aortic valve area. The third situation that I haven't discussed with you is that some patients don't augment their stroke volume with or their flow rate with dobutamine. So these are patients that have a lack of contractile reserve. And really, this is a non-diagnostic test. We can't really project out because we don't have enough of a trend to understand, what would this valve area look like at a normal flow state. So going back to our flow diagram here, so we started off with low flow, low gradient AS with a reduced EF. And we recommended proceeding with a dobutamine stress echo to confirm the severity of AS. So if we confirm that a patient has severe aortic stenosis, then these patients have class 1 recommendations for proceeding with an aortic valve replacement, whether that's surgical or through TAVR. For patients who have pseudo-severe AS, these would be patients that we would continue to manage conservatively. But there are patients that will also have indeterminate results, and we'll come back to those. Just briefly about, is this practice of using dobutamine echo, what supports this? Because, some people might argue, do we really need to prove that they have severe AS? They have a low valve area, they have a reduced EF. So this TAVR Unload trial was, as you might recall, a trial that looked at patients that had moderate aortic stenosis and heart failure with a reduced ejection fraction. And what's interesting is that about half of patients that were enrolled in this trial actually had a resting valve area of less than 1, and they qualified because by Dobutamine echo, they had pseudo-severe AS, where the aortic valve area increased into the moderate range. And so when the trial showed no differences between earlier treatment with TAVR versus conservative management, this really supports the notion that if we can identify patients that don't have severe AS by dobutamine echo, then we can, safely, conservatively manage these patients until it becomes truly severe. Okay, let's change gears here and go to another case. So this is a case of a 75-year-old woman with atrial fibrillation, CKD, type 2 diabetes, who's presenting with worsening shortness of breath. On her echo, you can see that she has some hypertrophy of her LV walls. She has normal systolic function, but ultimately had kind of a small left ventricular chamber. On inspection of the aortic valve, it's calcified, it's somewhat restricted. It's a little bit hard to see the valve, but we suspect that there's going to be some aortic stenosis here. So she had a normal blood pressure, and here are the results of her echo. She has a small LV size with a normal EF of 70%. Her peak velocity was 3.6 meters per second, mean gradient 31, a low stroke volume index of 31 mils per meter squared, and aortic valve area of 0.85 centimeters squared. So what would be the diagnosis that you'd give for this patient? So the working diagnosis for this patient, looking at the fact that the valve area is less than 1, the stroke volume index is less than 35 mils per meter squared, and we have non-severe gradients, would be severe low flow, low gradient AS with a preserved EF. But the question I would have now is, is there further confirmatory testing that you would proceed with to inform your management here?
Dobutamine stress test.
So yes, I've made you very excited about dobutamine stress tests, right? So it is generally not recommended to do dobutamine stress tests for people in this preserved EF category. Although it hasn't been studied in a large scale, there are concerns that one, are not going to augment their flow state because they already have a normal EF. There are some concerns from a safety perspective, especially if people have a hyperdynamic left ventricle or small LV chamber size, that sometimes you can induce hypotension. That hasn't necessarily been borne out in small studies. But generally, it's not recommended to do dobutamine echo. It still is recommended to proceed with a confirmatory test, and some of you may have seen the aortic valve calcium score. So this patient got an aortic valve calcium score by CT scan, and it came out to be 1631, which is above the threshold of 1200. And that would be confirmatory of severe aortic stenosis according to recent guidelines. So this patient was treated with a TAVR, and again, she had improvement in her symptoms following TAVR and did well. So just a word about CT aortic valve calcium score. So this is based on multiple studies that have evaluated this and using CT to be able to derive a calcium score of the aortic valve. The largest study that has studied this is summarized here, where they used patients that had echoes with agreement between their gradients and their aortic valve area as the basis for the diagnosis of the AS, and then they looked at what the valve calcium scores were. So looking at men, when they used a threshold of about 2,000, so a little over 2,000, they had a good diagnostic performance of the calcium score with a sensitivity of 80% and specificity of 82%. So pretty good test. For women, the threshold is lower, which is thought to be due to more fibrosis and less calcification for women. So the threshold is about 1,200 or about 1,300. And the sensitivity is quite good at 89% and specificity of 81%. And so this study, as well as its predecessors, have really informed our guidelines. And the calcium score has been included as a recommendation into to be considered based on the 2020 AHA guidelines and is more firmly recommended by the recent European guidelines using these thresholds that I've shown here. So for patients with low flow, low gradient AS with a preserved EF, the guidelines recommend an aortic valve calcium score. If they have severely elevated calcium based on these sex-based thresholds, then that would be confirmation of severe AS. And if the patient is symptomatic or has other indications, they should proceed to AVR. Based on the European guidelines, they would say that if your calcium score is low, then that would be considered to be not severe. So we could think of them also as having pseudo-severe aortic stenosis. I think we'll get into some of the concerns about calcium scoring that I have at the end. I think that, these patients, we we don't want to just use a single number to inform management. And so, I think we have to use our best clinical judgment here. And, if a patient's symptoms are seem to be explained by the aortic valve, we've done all of this up above of confirming our echo measurements. We're making sure they weren't significantly hypertensive at the time of echo. This population of patients, we have to be a little bit more thoughtful about appropriate management here. The guidelines would recommend treating as moderate AS, but I think we have to think of patients individually here. We do, just going back to the reduced EF patients, I mentioned that some of these patients will have indeterminate dobutamine stress test results. And it's recommended in these patients to proceed with calcium score, and again, using those same thresholds to determine severe versus pseudo-severe AS. So I mentioned, that measurement error is important and we need to be able to accurately diagnose these patients. We need accurate measurements. I just want to expand a little bit further of, some of the concerns that can arise that lead to misdiagnoses for patients. So because there are three measurements that we need to make to be able to derive an aortic valve area, that means that there's three opportunities for us to cause an error that gives us a faulty aortic valve area. So starting with the LVOT area measurement. So this is the most frequently cited cause of having a misdiagnosis for an aortic valve area. And we need to make sure that we are fully opening the left ventricular outflow tract. It's easy to underestimate. The concern is that we're squaring this in our equation, and so this can lead to even greater magnitude of errors. And whenever we measure this to be too small, this can both inappropriately result in low aortic valve area as well as low stroke volume. So when you're following patients over time and you see that there's been a significant decrease in the aortic valve area, but some of the other features of the echo seem similar, pay particular attention to the LVOT diameter or area that is reported, because just a simple decrease in the diameter can have a big effect on lowering the aortic valve area. And one thing that remains quite constant for patients over their lifetime is the LVOT area and size. And so that really shouldn't be fluctuating from echo to echo. So pulse wave Doppler, which we discussed earlier, where we're trying to sample the velocity of blood just under the aortic valve. This can also lead to faulty measurements, especially what I see is oftentimes the pulse wave sample is not quite close enough to the aortic valve. It's too low into the left ventricle. And this can inappropriately decrease the velocity, which can result in a low aortic valve area and a low stroke volume. And then finally, continuous wave Doppler is so important to be able to determine what are the gradients across the aortic valve. And so it's easy to underestimate this if we're not appropriately aligned with the flow of blood. So it's very important that our sonographers are measuring these gradients from many different places, not only the apex where you can see it, but using non-imaging locations such as the right parasternal, the suprasternal area. These are frequently shown to be the places where we have the highest measured gradients there. So it's important to be very meticulous with that. The other thing I wanted to mention is the effect that blood pressure can have on aortic valve assessment. And this is particularly true for these patients with low flow, low gradient AS with a preserved EF, because their flow state might be low just because of hypertension itself. So this is a study of patients undergoing invasive cath. And this is a representative patient where the patient was severely hypertensive at the time of their invasive cath. Here you can see that in the setting of this severe hypertension, there wasn't really as big of a difference between the LV and aortic pressure tracings. The patient was then given nitroprusside to normalize their blood pressures. And you see that there is a higher gradient, more significant gradient between the LV and the aortic tracing here. They also showed that there was a significant increase in stroke volume as well as increase in aortic valve area. So this is important that for patients that are getting echoes who are severely hypertensive, this can have, a significant effect on our results, and we should consider repeating these studies to have better diagnostic clarity of how bad is the aortic stenosis. Okay, so the last remaining condition that we haven't talked about yet is normal flow, low gradient aortic stenosis. So this will be case number 4, which is a 74-year-old woman with hypertension, CAD, and AS who is also presenting with worsening shortness of breath. Her echo shows that she has a normal LV size and systolic function with an EF of 70%, a peak velocity of 3.5 meters per second, mean gradient 31, and a normal stroke volume index of 36 mils per meter squared. Her aortic valve area is 0.7 centimeters squared. So I kind of already gave you the diagnosis at the beginning. This would be a patient with normal flow, low gradient, severe aortic stenosis. And so this patient also underwent a CT aortic valve calcium score. And interestingly, it was 700. So that would be consistent with moderate aortic stenosis. And because of the significant discrepancy between the patient's symptoms and the calcium score, as well as the low gradients, the patient was recommended to have an invasive valve study, which showed a mean gradient of 26 and a severely low aortic valve area and aortic valve area index at 0.9 and 0.56, respectively. So this invasive measurement confirmed a severely low AVA, and the patient was considered to have severe aortic stenosis and treated with TAVR with improvement in symptoms. So briefly, what is the recommended approach to normal flow, low gradient aortic stenosis? And this is where it gets tricky because, first of all, the 2020 guidelines from the US don't actually include it at all. They don't provide any information about this phenotype of aortic stenosis. The recent 2025 European guidelines do specifically say that severe AS is less likely for these patients and cite the fact that prognosis is similar to patients with moderate aortic stenosis as the reason for that recommendation. But what is going on? Why do we even have patients that have normal flow still having low gradient AS? And this is partly and in a large proportion due to the fact that we've set these thresholds for severe aortic stenosis and kind of assume that an aortic valve area of 1 is going to be equivalent to a mean gradient of 40. But that is not necessarily the case. And this is a nice study that showed that that's typically not the case. So this was done over a decade ago where patients with aortic stenosis underwent echo and invasive catheterization to look at their aortic valve area and their mean gradients. And so the invasive measurements were in orange and echo and blue. And you see a similar message here, which is that when patients have an aortic valve area of about 1, their mean gradient is less than 40 typically. So anywhere from the 25 to 32 millimeters of mercury. Um, and looking at echo and specifically at patients who had a normal flow state by stroke volume index of 35 mils or more, shown in this small dotted line here, you can see that when patients have an aortic valve area of 1 centimeter squared, their average mean gradient would be about 28. And it's not until patients have an aortic valve area of zero point 0.8 that they would have a mean gradient of 40. And so you can see that our thresholds are not entirely consistent with each other. And that creates this gray area between small aortic valve area and not severely elevated gradients. Well, then, as clinicians, what do we do with this? How do we manage patients? Observational studies don't really help a whole lot because they're, despite the European guidelines quoting that prognosis is similar to moderate AS, the studies actually are pretty mixed. Some do demonstrate mortality improvement with aortic valve replacement. Others, showed that we should manage similar to moderate AS. So they're a bit conflicting. What's interesting is that in our two most recent large TAVR trials, the PARTNER 3 and Evolute low risk trials, these patients with normal flow low gradient AS were included in these trials. So we are treating these patients in the context of severe AS trials already. This doesn't necessarily answer the question, but I think it sheds some light on this. So we had this question about these patients with normal flow, low gradient AS, and wanted to look at changes in quality of life after TAVR. So this is data from the University of Michigan patients undergoing TAVR. And we compared what does the quality of life at 1 year after TAVR look like for patients with our kind of standard high gradient aortic stenosis shown in the left versus patients with normal flow, low gradient AS on the right here. The different shades of blue are increasing improvements in quality of life that we see here. And you can see that there was no significant difference between the improvements in quality of life that we see with these normal flow, low gradient AS patients. And that really suggests that in well-selected patients who have normal flow, low gradient AS, we expect they probably will have significant improvements in quality of life. Is that enough to recommend this on a wide scale for patients? That's not enough strong enough data, but I do think that we have to consider this population of patients, especially if we have confirmed echo measurements and we're confident in our AVA being less than 1. So finally, completing this flow chart here, for patients with normal flow low gradient AS, if we confirm measurements, their blood pressure was normal at the time of echo, and we confirm severe AS, although the guidelines are not very specific about this, I do think that we have to be thoughtful and consider in carefully selected patients TAVR or surgical AVR. And then finally, just some last remaining thoughts about aortic valve calcium score, because with the subsequent iterations of the valve guidelines, there's a even stronger focus on using aortic valve calcium to confirm the severity of aortic stenosis. But there are also there's emerging data that would suggest that maybe we should do this cautiously when we're treating patients, because This study out of Jack Imaging, which was published last year, looked at patients who had low flow, low gradient AS with a reduced EF, and they performed dobutamine echo on these patients to as the gold standard for the diagnosis, and they compared aortic valve calcium scores based on compared to the final diagnosis. And so this is shown in men, but women have a similar story here, which is that for patients that had less than severe calcification, we see that 44% of patients still had severe aortic stenosis. And patients that had severe calcification greater than 2,000, 55% of patients had moderate aortic stenosis. And you see that there's really no difference based on the calcium score. And that's true even if you select different thresholds. There's not a consistent message that higher calcification led to more severe aortic stenosis. And then we have been involved in a study that we're looking at local data of all patients undergoing invasive aortic valve studies for low gradient aortic stenosis. So this is based on 294 patients here at the University of Michigan. And we looked at invasive aortic valve area as our gold standard and compared aortic valve calcium scoring to the final diagnosis of AS severity. And you see here, so this is called an ROC curve, where if you were flipping a coin and calling heads or tails to determine whether somebody had severe AS, you would expect that to fall along this gray dotted line here. And you can see that the AVC score was as good as flipping a coin for these 294 patients. So I think, from some of this emerging data, I do think we have to be a little bit cautious about our application of aortic valve calcium score to those low flow, low gradient patients that I discussed with you. And we really have to be thoughtful about, their management, take the whole clinical picture. So to summarize, when we're dealing with patients with low gradient AS, flow state is a very important aspect of this. So patients who have low flow will have a stroke volume index of less than 35 versus those patients that have normal flow. The low flow patients can be divided based on their ejection fraction into low flow, low gradient AS with a reduced EF or low flow, low gradient AS with a preserved EF. And those patients with normal flow would be considered normal flow, low gradient AS. So in conclusion, aortic valve gradients are flow dependent. And so we need to consider the flow state when we're evaluating patients with low gradient aortic stenosis. Meticulous echo measurements are really essential for making this diagnosis so that we're providing an accurate aortic valve area. And confirmatory testing is typically recommended to confirm AS severity for these patients.